So it's 4 o'clock, the music's gone off, so I'm assuming that's my cue. So I just wanted to welcome everyone to today's webinar as part of the Ventember event, the long-term ventilation Ventember event. My name's Sophia Tizani. I'm the lead nurse for the North Thames Paediatric Network, and we work very closely with Well Child and with the South Thames Paediatric Network, amongst others, to form the Pan-London LTV collaborative. So again, I just want to say a big thank you to Aerogen for sponsoring this event. Otherwise it wouldn't have been possible to put it together, and obviously all of the wonderful speakers that have spoken all the way through September, and again to those that are going to be speaking to you today. We've got a fantastic lineup, really interesting things to be discussed today. So today's webinar, you probably already know the title, is really a peek into the future of long-term ventilation for children and young people. It's really the focus of today is really looking forward. It's a changing landscape, long-term ventilation and non-invasive ventilation, and it's anticipated to get more and more and bigger as time goes on. So it's really a look at how that is going to affect our services and the way that we may need to adapt going forward, both in the way that we work and also in the technology aspect. So we have been really quite lucky to have speakers. So Cara Bosley from, she's a consultant respiratory specialist at King's College Hospital, who's going to speak to you. She'll do the first part of the webinar today. And that's really going to focus on how the long-term ventilation community is changing. And then the second half will be a host of other speakers that I will introduce as we go along. And that's really looking at the advances in technology in ventilation going forward. So there is the facility to ask questions along the way. If you could pop them into the chat box, and then we will pick them up at the end. There'll be an opportunity for questions and answers. If questions come to you after today's webinar, you can always utilise the links either through Twitter or through the email address, and pop your questions through, and then we'll try our best to answer them or forward them on to people that will be best placed to answer those questions. So without further ado, I shall hand over to Cara.
Hey, thank you so much for such a lovely introduction. So you should be able to see my slides now, can you? Okay, so thank you for giving me the opportunity to give this talk. And preparing for this talk, it has made me look at the landscape and how it's changing quite differently and how we need to think. Really what I'm going to be doing in this talk is really looking as well to the future of how the long-term ventilation community is changing for paediatrics, but actually also into adulthood. So my overview, I'm going to talk about the early history of ventilation, the development of long-term ventilation in childhood, use of non-invasive ventilation, and I'm going to be discussing how the types of paediatric patients on long-term ventilation have changed across the years, and the changes in prognosis of certain conditions that probably will map the provision of LTV service in the future, and how we need to adapt to this change. So first of all, just to talk about the earliest ventilators, the earliest kind of non-invasive ventilators that came about. And these are shown here. These were the iron lungs, and they're actually negative pressure vents. And these were used and were developed actually in the polio crisis initially because of the significant paralysis that they saw in the early 1900s, secondary to polio. And actually the first set of iron lungs was actually used in an 8-year-old girl who had a significant respiratory failure secondary to polio. And this was used in 1928, and she showed a dramatic improvement in in her respiratory failure following this. So look at all these iron lungs lined up. So things have changed a lot since then, but an interesting principle. So positive pressure vents then followed in the 1950s, and moving on from there, actually in the 1990s, this was when the first children were actually sent home on home ventilators. And there was a shift from children ventilated for days and days, and still we think that they are ventilated and they stay in hospital for a long time, and it would be good to cut these times, but actually back then they were virtually in hospital forever. And actually in the 1990s it was quite amazing that children were started to be sent home on long-term ventilators. So long-term ventilators is defined actually as daily ventilation. It doesn't have to be 24 hours a day, but some sort of daily ventilation for at least 3 months. Okay. So following on from the 1990s, one of the first studies, which was published in the BMJ questionnaire study, looked at the numbers of children home ventilated and the numbers of children on long-term ventilation. And across the UK, from the data from 1998, which was published the following year, there were 141 patients at that stage ventilated at home. That were on long-term ventilation, and 68% of those were ventilated at home. And these were the, on that study, these were all the patients that were mapped across the UK. And you can see there were more patients in London than anywhere else, but there were other patients in Scotland and across the north as well. So how about non-invasive ventilation? So this can be used intermittently, or so that there's a period, there has to be a period of 8 hours of gap for this to be used longer term, but actually for palliative care, it can be used for longer. And the masks that we use now have improved significantly. The ventilators that we've now got, we're really lucky with. They're amazing, and these have improved, and this has helped to expand the number of children on long-term ventilation. Now, a non-NIV can be used across age groups and across disease cohorts that I will describe later. And there are some patients that are on shorter periods and weaned off, and the most likely patients for this category are those with chronic lung disease or upper airway conditions, which as they grow and their lungs grow, they do improve and come off the ventilator. Some patients are on longer term use. So going on to looking at the kind of natural history, if you like, of long-term ventilation and how things changed over the years. Further to that study in 1998, Colin Wallace published a further study which looked at children on home ventilation across the UK, and it's shown here. And you can see even in that time period, in that 18-year time period, this exponential increase in long-term ventilation. And at this time, rather than the number of patients at home on long-term ventilation being in the 60s, this has gone up to 92%, which is much more preferable. And also within that group, they looked at the age categories, and as you can see, a large number of children were in the 16 years plus, and therefore starting to transition to adult services. And in the past 10 years, this has expanded further, and you can see how it's quite evenly distributed up to 16, but then there's a large number in there. And so the National Confidential Inquiry into patient outcome and death did do a further look at a census, and this is actually the most up-to-date census that I can find on long-term ventilation. And they found that between 2016 and 2018, there are 3,061 children and young adults on long-term ventilation shown here. And but this is obviously over a 2-year period, and this does go up to the age of 25, so older than the previous study. So you can see it going up here. These, as you can see, what's interesting, so the light pink is the non-invasive ventilation and the darker pink is invasive ventilation. So there tends to be more in the way of invasive ventilation in the early years, which goes down, and the non-invasive tends to kind of increase slightly and continue to go up. It's about 21%, so about a fifth of patients are on invasive ventilation. Now, this is likely to be an underestimate. It's difficult to quantify across the UK. I think this is the most up-to-date census, and I think you have had a session from NCPOD describing this data. We can see from this there is an exponential expansion, and services will need to react to this, and will need to react in the future to this too. So how about the categories of need for long-term ventilation, specifically in childhood? So this table here, this graph here, is the single centre non-invasive ventilation data from the Royal Brompton, and this was published by Michelle Chatwin, and this shows the difference, the change from the 90s to 2011. Okay, and you can see here that there's a small number of patients with chronic lung disease, and the rest of the patients being neuromuscular patients. Okay, so really two categories in the early years, and as time has gone on, there's been lots of categories added to this. And now here in 2011, which now is nearly 10 years ago, so in a sense, the data from NCPOD is more up to date with regard to this. There are now a larger number of children with different syndromes, so that would be inclusive of Down syndrome, would be a large proportion of those patients, and then a larger number of patients with obesity, those following cardiac surgery, those with upper airway problems, all going into the mix of these patients. And you can see the increase in number of patients with LTV, shown here. And this is the NCPOD data when we're looking at the different disorders and proportions of disorders of patients, of children on long-term ventilation. They can see the largest categories, a third of patients are those with upper airway obstruction and obesity. Then the second one, again, about a third, just under a third, are the musculoskeletal disorders. These will include the neuromuscular patients. And then the next category is children with central nervous system problems. Okay, and actually those with chronic lung disease only account for just under 9%. And this is interesting data, I think. So how are things changing? So this is a bit of a schematic diagram of how things have changed over time, which I've developed from looking at the data from these papers. And really what we're seeing is respiratory long-term ventilation increasing in total, although possibly in the future there'll be less patients with cystic fibrosis needing long-term ventilation. I'll talk about that. Those with chronic lung disease will increase as mortality has improved, and those patients with interstitial lung disease and pulmonary hyperplasias, there are more of those patients now. And then again, all of these categories, so central nervous system disorders will increase and are increasing. We're seeing increasing numbers of these patients. Those with neuromuscular, really in the 1990s and even in the early 2000s, the patients with neuromuscular, there was still a small category, and now that's really has increased. And there have been more patients now started on long-term ventilation. And again, the same with the syndrome, small numbers initially, which have expanded, and the same with upper airway disorders. And then two new categories, I think, if you really look at the tease out the data, there were very few patients with who were so obese that they needed to have NIV for obstructive sleep apnea in the early years. This is really a new category that we're seeing. And then palliative care, and I'll go on to talk about that. So these are categories that we weren't seeing in the 90s that we are now seeing now, and I think will continue to expand. So how about chronic lung disease? I'm going to go through each disorder and explain why I think there might be a change in levels in the future, and then talk about how this will impact on our services. So the prognosis has markedly improved for premature babies. So there are many more babies that are born at 23 weeks that will survive, and therefore there are the numbers of patients with BPD and chronic lung disease will increase with time. And therefore more babies are going on home on long-term ventilation. I struggle to find data to give the exact numbers of actual patients with chronic lung disease going home on ventilatory support, and that might be something for research for the future. It would be interesting to know, but I struggle to find the actual specific data for that. But this is what I have found is the incidence of, this is that very up-to-date data that's just in press and about to be published. So this is the incidence of BPD at the different gestational ages. And as you can see, still the incidence of BPD is very high in the babies that are born less than 27 weeks. And a large number of these patients will go home on home oxygen. But a large number of those patients will also need long-term ventilatory support, and we need to try to transition to that long-term ventilation in a smooth way and ensure that there's provision for support. And these patients, I think, are the ones that are the transient need for LTV, with numbers expanding, but for shorter periods of time. So these patients will grow their lungs and then improve and come off, but they still we need to think about how we provide care for these babies. And then moving on to myopathies. So this is this was a big area, and Anita Simmons, who first did the first study on looking at patients with myopathy. Actually, this study that was published in 1998 were different myopathies. They weren't just Duchenne's muscular dystrophy, and they didn't actually have a control arm because they thought this would be unethical, and they looked at patients. Sorry, these were all Duchenne muscular dystrophy patients, and they looked at Duchenne's patients who had already diurnal and nocturnal hypercapnia, and these were mainly adults actually, but some older teenagers, and they already knew that the life expectancy without NIV was about 1 year, and then if you look on this percentage survival, the survival much improved on NIV, so it wouldn't have been ethical to have an NIV arm. So you can see here 85% survival at 1 year and 73% 5 years, which is massive. And further on following on from this, the childhood series has been published. But interestingly, another paper has been published looking at survival probability, and it's shown here. And you can see that actually now, those with congenital myopathies have a greater chance of living into adulthood, shown here. Look at this survival probability. And actually, those with Duchenne's muscular dystrophy now are living into the 30s and 40s, mainly because of NIV. But what this means is that we need to provide provision for that into adulthood and also through transition. So how about SMA? We've been talking about Duchenne's, so how about SMA? So historically, and certainly in my lifetime as a paediatric pulmonologist, there was always ethical dilemmas about SMA children. But then this wonder drug has come along, which is phenomenal. This new drug, which is nusinersen, causes upregulation of the SMN with the ASO, and what this does is the spinal muscular atrophy proteins are increased and more abundant, and thus reducing the incidence of motor problems in this group. And actually, the improvement in motor milestones is quite phenomenal. If you can see here, so these are the survival curves, but actually the motor improvements, 51% improvement in motor milestones, and the risk of death reduction is 63%. So really amazing treatments. And actually, this therefore means that patients with SMA will now live a lot longer, and this is shown here for the survival curve shown here. So this is the nusinersen group, and this is the control group, and you can see how much their event-free survival goes on and on like this. So there's a massive improvement. Now, the thing that we are not so sure about is how this will affect the respiratory needs. So some of the early studies have shown that they still needed, in the group having this drug, that they would still need persistent ventilation. Less, so 39% versus 68% in the controls, but they will still need some degree of ventilation. But actually, studies following on from this have shown that the earlier you give the drug, the better with regard to prognosis. And we may be finding, as this drug becomes even more developed, that we will show even more improvement with respiratory outcomes. But I think what this is doing is saying, actually in SMA, we should be ventilating these patients. Their survival is good, but that we will have larger numbers of children with SMA on long-term ventilation, and we will need to provide for that and support families with regard to that. And the CHERISH study is the one that I was talking about, where it showed that if you give this drug early, it will have a better effect. So yeah. So how about obesity? So this is really a pandemic, and the global prevalence of obesity has risen by about 47% from the 80s, the 1980s to 2013. And there are large numbers now in the UK of obese children. A third of children in year 6 are now overweight or obese, which is terrible. You know, their last year of primary school and they are a third are obese. We know that obesity has a significant risk factor for obstructive sleep apnea, and therefore a number of the more morbidly obese patients will need long-term ventilation in the form of NIV. We do know that CPAP does improve apnea-hypopnea index, desaturation, and visceral fat in this group. And we have large numbers in our cohort, certainly, of obese patients on non-invasive ventilation. And these patients are continuing to expand unless we can do something about the obesity pandemic. The graph shown here does show the interplay between those social issues and the prevalence of obesity. Possibly childhood poverty is something that is a bigger subject that does need to be tackled, which will also help with childhood obesity. How about cerebral palsy? So the incidence of cerebral palsy is stable despite improvement in perinatal care, and this was an interesting study that I found. Just a small number of patients that were presented with cerebral palsy at Great Ormond Street Hospital, and these had severe, most of these patients had severe motor impairment, basically, but what's shown here is the improvement in all of their parameters, their sleep parameters, following initiation of non-invasive ventilation. It was hard to establish them on NIV. Only 48% were established, compared to a lot more than that in the other population of NIV. But it did seem to improve outcome. But obviously, these patients we maybe need to think about. There are lots of patients with cerebral palsy, and I think it's really important that there are open and joint discussions with family. There needs to be a balance of burden of care versus improvement in sleep disordered breathing. There's no evidence to say that sleep disordered breathing improves seizure control or survival, but it might be something for research for the future. So this is another group of patients that maybe will expand, and one that we shouldn't ignore. How about palliative care? And this is definitely a new category of patients over the last few years. So these are patients that usually are given non-invasive ventilation, and they're giving for longer periods than in a normal setting, and it's supportive, and firm parameters have to be set. But it can be a bridge for home. It can make some children that are on a sad pathway of palliation and to death, it can reduce deaths on PICU and make them more controlled in a home setting. And the numbers of patients having NIV for palliative care has increased dramatically. There needs to be agreed written guidelines around end-of-life care, and an ethical framework has been written up in this paper. And as a group, as a service group, as a care team, we do need to be constantly updating frameworks and having discussions with families with regard to NIV and palliative care. And I think it's really important just to think about this, that we obviously want to correct our parameters that we're seeing, but there may be an increase in burden because of the possibility of prolonging suffering. There's also equipment issues, carers in the home and monitors, but possibly for some families, this would the gain of possibility of increased survival or improved behaviour might outweigh the burden. But these discussions need to be had with the family openly. So looking at all of this data, really, I think it shows that we do need to expand transition in long-term ventilation. There are increasingly more children are living into adulthood and going on to ventilation into adulthood. And certainly NCPOD found that 23% of patients were between 14 and 16 years of age. And when we're thinking about transition, we really need to be thinking of it from 14 years of age, from an early time. And another study showed that about 40% of patients had been transitioned in that period. This was the study from the Brompton. So I think we need to encourage interests with adult physicians, and obviously improve transition clinics and think about doing this from an early age. So what about conditions which might show actually reduction in numbers? Reduction in the community of LTV. Well, cystic fibrosis, I think, is one of them. So there's been a large increase in modulated treatments in the last few years, and now soon 80 to 90% of patients with cystic fibrosis will be eligible for modulated therapy. This will, I think, enable and mean that most people with cystic fibrosis will actually be in the adult community. There'll be a large expansion in the adult CF community. Children with CF, I think, are likely to be very well and are less likely to need long-term ventilation. Whether or not adults at a later stage may need LTV at an older age or not at all, we don't know. We need to see where this goes, but this data here does show the great improvement with triple therapy. So these are patients with delta F508 and minimal function for their genetics, so certain genetic makeup of the child with cystic fibrosis, or adults. And you can see here the change in lung function, FEV1 is up to 15% predicted, and the sweat test reduces by about 40. So these are massive improvements. So some patients will have then sweat tests which go into the normal range. Okay, and the same with the similar effects with the other genes, the delta F508 homozygous. So these results were published in the New England Journal, and they are amazing. And we're just starting some of our first patients on Dripple. I'm really excited to see the effects of that. So this is how things are changing. We talked about this. I think the future means that there's going to be further expansion of LTV services exponentially. Children are growing into their adulthood with their ventilators, and there's going to be a larger adult population on long-term ventilation. There will also be, I think, an expansion of adult palliative care in the community with LTV in the community for that reason. And I think the services is just going to expand further. So how do we adapt to this? I think we need expansion of MDT services for children with LTV. Transition needs to be expanded, and it's important to collaborate care pathways, not only across hospitals like we are doing, but also from childhood to adulthood. We always need to improve our discharge processes. I think on the NC-POD data, the average time in hospital was around 7.5 months. So if we could reduce that, would be good. And there's an increase in provision of adult long-term ventilation clinics and support. We need to do that. We need to increase, possibly we need to initiate some long-term ventilation in the community, certainly to help because of the COVID issues, I don't know, but that may well keep up with demand. And we need to think about training and definitely support for families. So these families have huge pressures put on them. They need respite, they need psychological support, and they need physical care structures in place. We need to put support in schools and workplaces, for also in workplaces for adults on LTV. How to summarise, long-term ventilation in the community is expanding exponentially. It's essential that we improve discharge pathways and reduce inpatient stays. It's important that we recognise and accommodate the care for an expanding number of children, and also think about the conditions that we will be treating and treat them together. It's all important that we expand our support services for families and also our support services for adults on LTV. I think transition is a big thing, and that's really important for teenagers. And we need to expand our adult clinics and support to accommodate the increasing demand. And that's any questions?
That's wonderful. Thank you so much. There are quite a few comments and questions actually in the comments box. In the interest of time, yeah. What I would suggest, if you can see, thank you for everybody that have made comments and asked those questions. Just in the interest of Cara, if you would mind having a look at the comments box and just answering, I suppose, as many as possible. And then when we get to the end of the whole webinar, we can try and pick a few bits up and have some more discussion with the panel. Yeah, does that sound okay?
Yeah.
That's wonderful. Thank you so much. That was really, really interesting. So without further ado, we'll move on to part 2 of this webinar series. Of today's webinar, and I will hand over to Richard Chavez. I hope I pronounced that correctly, who is a paediatric respiratory consultant at St George's Hospital, that will just give you a brief overview about the LTV equipment and collaboration across the trust and the region. So this second section really will focus on the advancing in technology. So again, just like with the first half, if you can pop your questions into the chat function, and we will come back to them at the end. So without further ado, Richard, I will hand over to you.
I think, Miriam, are you controlling the slides? So first I said, so I've got just 5 minutes to just run through one of the groups that we've organised through the North and South Thames Paediatric Networks, and this is looking at an equipment working group. So it's involved clinicians from all of the 6 centres that start children on LTV in London, so Great Ormond Street, the Evelina, Brompton, King's, St George's and Barts, and that covers children over at the whole of the sort of southeast and home counties, and probably, I mean, somewhere around about a third of the UK's population of LTV children, so well over 1,000 children. And I think the reason the group started was because there is a large variation in procurement, the methods that different centres use, and the equipment that people use, and that has impacts on training both for DGHs, for community staff, and the way that the system works at the moment as children sort of are treated in probably a slightly haphazard way across the area. So we wanted to try and see if we can work on that. So next slide. And some of those issues obviously came up in the NCPOD report. So looking at ways that we standardise arrangements for LTV equipment, how we purchase it, how we service it, what consumables are used, and how we best organise those. And they also picked up on inequalities between families, so why one family gets something and another family gets something different. The different costs that CCGs face depending on the way that services are bought or commissioned. So next slide, please. Oh, here we go. So I think the other thing is that LTV equipment, and we've sat down and we've brainstormed through this, and I've stolen this slide from someone else, but at the moment equipment, obviously doesn't just include the high-tech stuff like ventilators, but all sorts of other equipment, from cots to saturation monitors to suction catheters, the lot. And at the present time, different parts of the care around the child provide different bits of that equipment, and so all of these things do lead to variations. All of them lead to potentially to delays in discharging the child, and it's kind of not a one-stop shop. So again, we're not just looking at the high cost bits of equipment such as ventilators, we've got to look at the system as a whole. Next slide. Coming back to the ventilators, we've looked across the patch at the different ventilators that the centres use, and there's quite a bit of variation. Clearly there's a variation on the patient needs, and so some of the high-tech or higher tech ventilators that we might need to use for a trachea-ventilated infant are not so appropriate for a child who needs even complex NIV, and certainly not those who are needing CPAP or lower, less complex NIV for other conditions. And so we will have a range of machines, but if we can perhaps limit that to a smaller number of machines for each indication, that will help us with our training across the patch, standardisation of care, and potentially onto sort of the budgeting. So next slide, please. So what we're going to be working on, and this is still work in progress, is some sort of clinical standardisation. So which ventilators should we use for which condition? And as I say, that will include trachea-vented versus complex NIV and the more standard NIV for obstructive sleep apnea. How we should be commissioned for those, and whether that's through CCGs, through NHS England, and can we somehow make one standard way of commissioning so that everyone gets the same process, smooths it through, and that will help the discharge process as well as the finance side of things. At the moment, some units do in-house servicing of their machines, others get servicing through the companies. Again, can we look at one system for the whole of that area? And then how does that relate on to training? So obviously, if we've got a limited number of machines, we can, we could standardise training packages. That means that once we've discharged a child into the community, it doesn't matter which centre they've come from or where they might end up if they run into difficulties. People will be au fait with that particular machine, and it will just standardize or make things more straightforward. And as I say, it's not just about the ventilators. I mean, cough assists, suction catheters, cots, everything. If we can try and get your sort of package of care, your thing, liken it to an Ocado or Sainsbury's to you at home, or some other supermarket, if we can just order things in one standard way for all patients, we could do that in a quicker, more efficient way, and have that budgeted differently. So I think that's our vision. Next slide, sorry, the last slide. It's just that we want to look to see if we can develop a streamlined way for obtaining equipment for children and young people who require LTV, so it's easily procured, accessible, serviced in financially sustainable ways, so cheaper for the for the NHS overall, and much better for patients.
That's wonderful. Thank you very much. And I think you're absolutely right. I think this is definitely the way forward. So I will now move on to Patrick Murphy, who is a adult respiratory consultant at Gars and St Thomas's, who is going to speak to you about Lane Fox and what paediatrics can learn from the adult model with regards to procurement and equipment.
So I was asked just to talk about what can paediatrics learn from the Lane Fox model in just a couple of minutes. So hopefully I'll stay to time. And I'm sure there's lots that we can learn from paediatrics. And so what I'm going to do is just really talk a little bit about the service as a whole, mostly in terms of new technology. I'm going to leave that to Hira and Rob, who are going to talk about remote monitoring and some of the other new technology. And I'm going to really focus on how the service is structured and how we, deliver the care for the patient, because that's one of the main things. For those of you who don't know why we're called the Lane Fox unit, so Felicity Lane Fox was a baroness in the House of Lords who was a benefactor of the unit, and she was a survivor of the polio epidemics and was a long-term ventilation user and a real disability advocate. And up at the top you can see the sort of where we're based at St Thomas's, and down at the bottom there where it says there's the nice wooden building saying Lane Fox Remio unit. That's really the future of our service, in that we've expanded from a single site at St Thomas's with 14 beds that was very much a respiratory critical care facility, to the centre at Remio, which is a 20-bedded really long-term ventilation and step-down unit towards community provision and assist with carer training and so on. And as I talk about how the service is structured, I think it'll become clearer why that transition period is needed. But I think it's important to have a look at that. You've seen this photo before, which is the iron lungs from the polio epidemics in the 60s, but the reason to mention this is that this is very much not home ventilation. This may be long-term ventilation, but you can see there's dozens and dozens of patients all lined up in iron lungs, very much in a hospital setting. And this is a picture from the film Breathe, which was a biopic of Robin Cavendish, who was a patient under Geoffrey Spencer, who was the founder of the Lane Fox unit. And he developed the very first wheelchair mounted ventilator. And really it's from pioneers like this, from patients that show us, and led the way, and really how the ethos of the Lane Fox unit has developed in terms of empowering patients for home ventilation and not just supporting long-term ventilation in community facilities, but really genuine home ventilation. And I'll just give you two examples of two of our patients. This is obviously being shared with the consent of both of these patients. This is Martin on one of his adventures, doing the coast to coast in an adapted wheelchair and on top of the Millennium Dome, and another one of our patients who's there with his son at the game at Millwall and on his wedding day. And whilst not all of us would choose to spend our time going to watch Millwall, it is important that we're able to support patients, you know, outside of hospital who are long-term tracheostomy ventilated, and really, you know, develop a service that is designed to deliver the care they need where they need it, and make it accessible for that patient group. This has been touched on again in the first talk, so repetition hopefully means that we'll all be remembering these data, but home ventilation is increasingly common, and this is just data from the Lane Fox unit, and you'll see when I started working with the service back into the 2007-8, there was around 100 patients set up each year, and now we're over 300 patients per annum. So, you know, year on year, there's been a big increase. This isn't the latest data, but this does just show where we're picking up that, you know, this isn't because, or isn't principally in adult services anyway, that there's a big change in the number of patients with neuromuscular disease or COPD, but actually obesity, you know, this middle group here, the obesity-related respiratory failure, or COPD OSA overlap, that's where there's the big increase in demand for our service, and that's obviously, you know, reflecting of the obesity pandemic that's been touched on. We are a sort of local, national and international referral centre. The red dots on the map on this slide represent the postcodes of all of the patients that we look after with tracheostomy ventilation, which is about 100 adult patients with tracheostomy ventilation. We look after about 2,000 patients in totality. So, you know, about 2,400 with non-invasive ventilation and about 100 with invasive ventilation. And you can see those are largely clustered around London, but actually we support right through to the south coast, into the Midlands and into Wales, because tracheostomy ventilation services are reasonably poorly provided for across the UK, and therefore we often find we need to support patients outside of a direct locality for St Thomas's Hospital. What's the makeup of the service? And there's a lot of people on here, but that's because it takes an awful lot of people to deliver the service that these patients need. We're principally a respiratory unit, and therefore, as I said, we've got a 14-bedded weaning unit at St Thomas's and the 20-bedded unit at Redhill, or satellite unit for weaning and home ventilation setup. And that really is the bedrock of the physical service. And then there's a huge number of people that support that, and that's right across the MDT. So from the nurses, both the inpatient and community nurses, transitional coordinators, physiotherapists, occupational therapists, you know, technicians, dietitians, speech and language therapists, as well as the consultants who are mostly respiratory, critical care and sleep trained. And it's that whole continuum that's needed to support the patients, because these patients have complex needs, and actually sending them to dozens of different clinics and different specialties, you know, is overly demanding. And as you'll know, if you look after patients who are long-term ventilated with tracheostomies, many parts of the hospital just cannot accommodate these patients, and therefore, you know, you really restrict their access to care unless you can provide it in a uniform fashion. As well as the respiratory care, we're really lucky to be supported by a range of complementary specialties, neurologists, rehabilitation consultants, as well as our paediatric colleagues, the cardiologists who help support those neuromuscular patients with neuromuscular cardiomyopathies, gastroenterologists who help run a PEG service that allow us to perform PEG insertions on even, you know, significantly unwell patients in respiratory failure with progressive neuromuscular disease. And that's really well supported by the anaesthetic consultants that developed a huge degree of skill in intubation, extubation to NIV, and supporting these patients through a range of procedures that they need to be supported through. I think equally as important as the clinical services, we have very much an active research service, and we've contributed to a number of national and international trials around home ventilation, and really are trying to help, you know, push forward that agenda. And I think any important, you know, lead service in this area needs to have an integration between clinical care and research to really best serve the patients. in terms of delivering IV, as I said, Hira and Rob are going to talk about this, but there's a range of different ventilators that are used, and thankfully technology is moving on, and it is important that we embrace that technology and use it where we can to support patients in the community to access care better. So really, just as an overview, of the service, is what can paediatrics learn. I'm not sure, because I think you probably do an awful lot of this very well already. It's really integrating the core elements of clinical care, education to other professionals and research, across the MDT that's vital to deliver a genuine service, for long-term ventilated patients, whether it be adults or paediatrics. Thanks very much for your time.
I was just saying thank you very much, Patrick. That was really insightful. I'll just repeat myself again. If you could, just with the interest of time, if you could, as Cara and Richard have done, to keep an eye on the chat and just answer any questions within the chat. I think it's probably a good way to do it, because it's there written for everyone to read as they go along, and also you can come back to the answers also. If I can hand over now to Mira and Rob, who will talk to you about the advances in technology. And then with the remaining time, perhaps we can open up any further questions to the panel before we end. Thank you very much.
Good afternoon. I wanted to first of all say we've heard quite a lot from Dr. Murphy about Lane Fox unit, and as far as the advancement of ventilation is concerned, before we go into that, just wanted to say that we have a policy where we buy ventilators in Lane Fox unit, and that covers medium, low end and high end, and it's disease based, but without boring you with Lane Fox unit and what it does, what I'd like to do is to ask Rory Maloney, I think he should be with us to talk about this slide about remote TC-CO2 monitoring. Is Rory there? Can't. Okay, so the idea is because of COVID, we are looking at telemonitoring, and we are looking at ventilators that we can download over the cloud and analyze the data and give the data to the consultant, so that that helps them to prioritize the patients and who they see. And for that, we've got Rob Chase from Philips, who is going to talk about the advancement in Philips ventilators. TCM monitoring is transcutaneous monitoring that at the moment is not used much out in the community, but because of COVID, we are starting to see usage in the community, and the way it is working at the moment is that someone via a courier, the device is delivered to the patient, and then after 24 hours or 12 hours, the device is collected and then downloaded. Whereas Dolby Vivasol is promoting a device that allows cloud-based monitoring, so you can actually download data live and see, which is useful because you can see whether the transducer is connected or not. I'm not sure whether this is something that will be useful in the future or not, but the slide shows you the control box, and apparently it works both with Centec and radiometer. So if you've got a radiometer device, it will also work with that, so you can download the data from the community into the cloud and then downloaded to your laptop. The next slide, if I can have, please. So this gives you the data from patient and a record of it, so you can go back and view. And the interesting thing is, although we are looking at advance into monitoring, question is, who pays for the data collection? We are not sure yet, although the companies are selling you a package. What will happen after 5 years? Will they turn around and say, give us a fee, or you don't get the archive data? Next slide, if I've got. Okay, so this is what you see. Although I haven't seen it yet, this is from Dolby Vivasol to see what information you get from your device if you're looking at it from live data collection. Many thanks. If we can now invite Rob Chase to take over.
Hi, my name is Rob Chase. I'm clinical manager of ventilation at Philips. Here kindly invited me to do a bit of collaboration to show what, from a manufacturer's point of view, that we're looking to advancing in terms of ventilation. And so I think it's been very well highlighted by Dr. Bosley and Dr. Murphy today that we as manufacturers are aware that certainly in the paediatric forum as well as in adults, that there is an increasing reliance on the services, and also that there's increasing numbers on the services. And so from that point of view, as a manufacturers, we are trying to do everything we can to make sure that we are supporting those services as much as possible. So the first part that we really work super hard on, and that in all our innovation now, is that we are really targeting a 0% failure rate in our devices. Globally at the moment, Philips stands less than 1%. We are completely aware that if in the community a device goes down, that is a huge impact, not just on the patient, but it impacts on the carers, it impacts on the service providing the device. And so is one of our main things that we test and check and see what happens with all devices, to make sure that we are putting reliability as our #1 technology advancement. With that, we also are changing the way that we look to have these devices routinely serviced. So some of our devices used to be yearly or 2 yearly. Our non-invasive ventilators, we've moved to being non-serviceable, which means that the likes of Hera doesn't have to call that in every single year to do a full service check, albeit they may have to locally pat check it. We have reduced the amount of service time down to have the impact, to the point where our life support ventilator there, you can see in the picture, the Trilogy Evo, only needs servicing every 4 years. That should have a tremendous impact on your services in terms of having to get them back off patients, get them reserviced, sending them back out. It should cut it down hugely. The next shift that we're seeing, and demand certainly from the community services and from paediatrics in specific, is the use of adapted and automated modes. I think there was a question in the questions about these automated modes. So we have modes of ventilation that are targeted to deliver automatic pressure supports or automatic EPAP. Traditionally, though, these are focused more on the adult airways and adult levels of resistance. So I think there's a question about automatic EPAP that works really nicely in the adult obesity hyperventilation syndromes and the obstructive sleep apnea, but it looks at pediatric resistance, adult resistance, whereas pediatric resistance to the airway is much greater, so you may not get an as accurate result. So as such, we will need to adapt our adaptive modes and our automated modes to being more pediatric specific. We are seeing a starting emergement of some of our volume targeted pressure support in the likes of treating CCHS, with Australia and France having some significant studies and findings from that point of view. So that's in terms of the actual device. But the other part that we have is whenever we launch a product, we always look at the care package that we can put around that product. And more than ever with the COVID, that we've actually seen that this education is forcing us in a really great way that we have to be more positive with our education. And so we will be increasing the amount of education we're putting out there in terms of virtual forums, online training, education modules. So for example, Philips has a Philips Learning Connection platform, but we are looking at making these connection and these education platforms actually trackable and traceable. So the likes of here, I can see who has done the training, which services have done the training, to be compliant with their own hospital services. We can also see that from our point of view as supporting, so someone like myself who goes in and educates in the community, we're actually going to start being more innovative and using virtual sessions more than ever to actually increase our flexibility to provide more training, rather than me having to, last year I managed to do around 23 sessions myself, but the whole team managed to do about 60 sessions of carer training. We reckon we can increase that because of the fact that we would cut down on the amount of traveling we'd need to do, and we can still provide the same level of training for you, but from a virtual perspective. And I think the adaptation and adoption of virtual training is definitely seemed to make an improvement. Next slide, please, Teresa. Oh, you've gone too far. Sorry, that's perfect. The next part, as here alluded to, and as Dr. Murphy has as well, is that data and telemonitoring has been really identified as going to be hopefully significant. So the likes, so recently at the European Respiratory Society, there was a lot of conversations around the use of telemonitoring, and whilst they're still looking at the long-term outcomes, we've seen in the short term, the use of data can make significant improvements and give insight into patient management. Things such as ventilation asynchrony, tidal volumes, patient trigger percentage, which can be completely in line with deeper level of sleeps, shows that data is becoming more and more important. But what we do see is that actually that data needs to be made more available and more accessible than currently. We do have problems in terms of sending data and the cost that are associated with data. So where the technology is going to advance in terms of those sort of deliveries of data, we will see advancements which should hopefully help all services to make sure they have more cost-effective service. The other part is that we currently have data management systems which we provide, and the data will flag up to the clinicians looking after these patients when a patient falls out of a certain parameter. This is very much a reactive parameter. So it's much like if a patient became unwell, they'd spike a temperature and you'd apply the medical fix. Whereas in our ventilation, it might be that they drop their tidal volume and it flags up to the clinician. It becomes a bit of a burden, this data, because you're having to be regularly checking it. Where we hope to move to in the next few years is by mapping what happens with all these patients and seeing what medical fixes have happened, to the point where we're hoping that we can get to a more predictive method of data collection and data presentation. So therefore, theoretically, we are seeing a trend change before the actual big issue happens. So therefore, we can suggest, or you would see these trends and be able to make a fix. So for example, the clinician sees a change in the chest function. They know that a temperature is going to happen, so they apply a medical fix beforehand. So we see that the switch towards predictive medicine is what's really going to aid the future outcome for data management. Where we really hope to get to is to have some form of AI or algorithms that will actually do that monitoring side of things for the clinicians. So it will already be identifying these patients rather than you having to continually have to look for these patients. And so that would be a case that the device is already telling you this patient's going to alert. You could probably fix this patient early on. So from a manufacturer's point of view, we're aware that data is going to be really crucial post-COVID. And so we're just trying to make it as useful and intuitive as possible. So thank you for that opportunity to come and speak to you.
That's wonderful, Rob and Hera. That was great. Thank you very much. So there are no other speakers. So I just want to give a virtual round of applause for all of the speakers that have have given wonderful insights into the future for long-term ventilation and patients and technology going forward. Let me pop my video on. We've got a couple of minutes actually left. I think there have been quite a lot of questions, and thank you, Cara and co, for answering those questions in the chat box. I just wondered if anybody had any questions, you can unmute yourself, pop your hand up and we can follow those through. Or if there's any roundup of kind of answers that you want to give from any of the speakers, from questions that you've had that you'd like to kind of address the rest of the learners with, that'd be great.
Thanks everyone for the questions. Yeah, I mean, there are a few questions on, there's a question on quality of life on the cerebral palsy patients. I suppose that's hard to quantify. They didn't actually look at a marker, but maybe the family could have given a marker of quality life. That might be something for the future. I think Richard brought up a really important point about the SMA children, which I tried to kind of talk about in the talk. I suppose I didn't really talk about it with regard to the SMA children. It was the, you know, the still difficult sort of ethical dilemma that SMA children will pose, that they still do have a reduced life expectancy. And although obviously this drug has improved their life expectancy and their motor milestones, there still will be a reduced life expectancy, and thus, you know, how do we know whether it's the right thing to ventilate these children? And I suppose we could have a whole other session on that. I think the main thing is to try to ensure that we adhere to the kind of ethical guidelines, and we have joint discussions with the family to try to help them make a decision and weigh up the burden versus the advantages. And obviously we're still collecting data on SMA and these new drugs, and how they're, you know, the earlier they give them, I think the better the outcome. But still, it does seem that these children will need a longer term ventilation, and I don't know if Richard wants to comment as well. But that's what I would say in response to that.
Wonderful, thank you. There was, yes, sorry, Richard. Richard has got his hand up, and there was a hand up from Helen, but that's gone down now. So
I think I was just going to come back, and I mean, I don't think it's just with SMA, but with all children requiring LTV, we have to go through the ethical pathway. We had a presentation on that a couple of weeks ago, but I think it's an important way going forward that we have to review that, and then review the progress of patients on an annual basis to make sure that, you know, we're still doing the right thing, and you know, the burden of care is considerable for all of these families. So I think just because there are new medications doesn't necessarily mean that what we can do we should always do. It's got to be weighed up on an individual patient basis.
that's a really fair point, thank you. Helen, did you have another question or comment?
Yeah, it's to Richard. I'm very interested to hear about the work you're doing on standardising the equipment. From a CCG perspective, it's been a huge nightmare in our area, in that we do not have any specialist teams locally, and we don't have an HDU, even level 1 or 2 for children that are ventilated. So we rely very much on tertiary centres, and we've actually currently got children that, if they're under the Evelina, most of the equipment is dealt with and is part of the package. But if they're from Brompton, St George's or Great Ormond Street, then it's down to CCGs to individually fund. So it works okay, but from a point when I raised that when a child's finished, there is a wastage of equipment because we can't reissue. We have nobody that can set children up. So that equipment usually just sits on the shelf, and can't be reused. That's an issue of waste, but also it's the governance and looking at who is taking clinical responsibility about training staff if that is reissued and reused locally. So I think by standardising it and having it from tertiary centres would, not just from a cost point of view, but I think from a safety point of view, would be a lot better.
So I think that's the point that we're sort of trying to get to, is that we, again, for ventilators, we agree a smaller number of machines that we will all agree to use. Obviously, as new machines come online and new technologies, we'll need to adopt those, and other things may drop off the end. But if we can commission them all, or we can all be commissioned in the same way, that the package of care includes the technology and some of the consumables within it, then we can provide that out from the centres in an equitable way. Training comes with that, and so on and so forth. And I think if there are machines that are have been bought by CCGs, either when the next child comes along from their area that we're going to be setting up, potentially those machines could be whatever the term is, revamped and reused, and with help with the companies. They shouldn't just be sat wasting away on the shelf, and if you've got a pile, we'd be happy to sort of take them back. So
thank you.
That's brilliant. Thank you so much. I suppose only one thought was we're planning to do lots of education and training with regards to LTV. So if there are any spare, this is my cheeky plea, but if there are any machines that are sitting around on shelves that could be used for training purposes, just for training staff, either out in the community or inside the hospital setting, just contact us. We'd be more than happy to take them off your hands. I can't see anybody else with their hand up, so and I think we have pretty much come to the end of our session. Like I said, if there are, it's been a really, really interesting session today. If there are any questions that are following this this webinar, if you could just email us on the central email, or you can contact us on Twitter, and then, like I said, we will forward on the answers to any of the questions to you. Keep an eye on your inboxes. In the next couple of days, you will receive a feedback request in the form of a Survey Monkey, and if you've registered and you fill out the Survey Monkey, you will receive RCPCH CPD credits. So we want to thank you very much for your attendance, both for those that have tuned in and for those that have presented, and I think we'll wrap up there.